So, as our audience know, ruxolitinib had been instrumental in the management of myelofibrosis patients. Can you briefly summarize to us the data with the COMFORT studies and the use of ruxolitinib for myelofibrosis?
Sure, absolutely. So Rux, as we normally abbreviate ruxolitinib, was FDA approved first in 2011 based on the Comfort 1 and Comfort 2 phase 3 trials, as you alluded to. Comfort 1 was a placebo-controlled trial, mainly conducted in North America and Australia. And Comfort 2 was a phase 3 trial comparing a Rux to best available therapy, mainly in Europe. And for both of these trials, the primary endpoints were 35% spleen volume reduction by imaging, and then also symptom improvement by different assessment tools. For example, Comfort 1 used the myelofibrosis symptom assessment form, and I believe the Comfort 2 used some other indices of symptom improvement. So in both of these trials, ruxolitinib was clearly statistically significantly superior to placebo or best available therapy for both of those endpoints. As examples, in Comfort 1, at 24 weeks, you had about a 42% spleen volume reduction rate with ruxolitinib, and a similar rate in reduction of symptoms as well. For symptoms, is usually a 50% reduction in the total symptom score. So it was clearly superior in both trials, and that's what got the drug approved. Important to mention, these patients were intermediate 2 or high risk patients with myelofibrosis, so a little bit more advanced phase of the disease, and also their platelets had to be 100,000 or higher.
Absolutely. So, uh, and like, where do you like initiate the treatment for those patients? So, which are the patients that you select for the ruxolitinib, and when do you start the treatment? Do you include the patients with intermediate one as well?
I think we've learned a lot since the comfort trials. There's been extensive experience in intermediate one as well, as you just alluded to. There were trials called the robust trial and the jump trial that included a large number of intermediate one patients. So yes, I'm comfortable using it in those patients. I typically do not use it in low risk patients. However, if a low risk patient is symptomatic, then I will use it, and this is endorsed by NCCN as well. And then we've also learned a lot about how to use it in the face of cytopenias. So per the package insert, you are not to use it with platelet counts less than 50, but for the most part, physicians have gotten comfortable with doing even that at low doses. And then the other thing you see is anemia. There's actually an abstract this year at the EHA meeting in June called the REALIZE trial, in which patients who had hemoglobins less than 10 could start at a lower dose. As you know, typically we dose ruxolitinib according to the platelet count. But in these anemic patients, they started with 10 BID, and after 12 weeks, they went up. And that was a successful strategy as well.
Right. Yeah, I think my practice is similar. Obviously, like patients that have splenomegaly, constitutional symptoms, I think those are the patients that benefit from it. I think both of the studies, the comfort eluded, or like they were not designed to look at overall survival, but both of them had a signal of improved survival. I tell the patients usually this is a treatment for symptoms, but patients, performance improve, their, symptoms get much better, that they do drive survival advantage indirectly, probably from the treatment. As you mentioned, I think one has to be aware of the cytopenias and the management. If I'm in doubt, borderline cytopenias, I start with a lower dose, but try to escalate fast. I
Mhm.
discuss with patients that maybe the symptom improvement are going to be seen very quickly within 1 to 2 weeks with even a low dose, while spleen response is a little bit more dose dependent
Mhm.
and needs more time to achieve. But there is no doubt that it had changed the management for patients, and the improvement that we see from the treatment for patients had been instrumental for their management.
Absolutely, and that survival benefit is very well established. It's now in the label, and as you rightly point out, it is dependent on the spleen response. So you do need to optimize the dose to get the best spleen response.